Good afternoon and welcome to Infants and Children Oral Health webinar. This webinar is designed for the practitioners in a primary care setting to integrate oral health assessment and the application of fluoride varnish as an evidence-based practice into the physical health exam for children. Using primary care settings such as medical providers' offices, school-based health centers, etc., helps bridge the gap in completing oral health assessments and improving children's oral health status. The webinar is also a teaching model to introduce the concept of the dental home and the need to develop referral sources for children's oral health needs. Introducing oral health assessment through the use of a dental caries risk assessment tool will identify the need for early intervention in children at risk. Our presenter is Janice A. Townsend, DDS, MS, Interim Chair, LSU School of Dentistry, Department of Pediatric Dentistry. There will be time for questions and answers at the end of the webinar. If you have questions, please type them into the questions section of your control panel. Welcome, Dr. Townsend.
Okay, well, thank you. Well, I'm excited to be here today to talk about infant oral health. This is a topic that, unfortunately, many people aren't aware of the importance of oral health for young children and small children, but thanks to presentations like this and grants associated with this, we are starting to raise awareness. And thank you for the picture. Okay, so today's objectives, we're going to introduce you to practicing oral health assessments in primary care. And I'm going to introduce a term that maybe you've heard about but don't quite understand entirely, and that's the concept of the dental home. We're going to talk about and look at some photographs of what is normal and abnormal in the child or infant's mouth, and we're going to talk about ways that we can intervene early to help improve children's oral health. Okay, so if you look at the photo today, I think this is a good reference photo. You know, people, especially physicians or people in the medical field, really don't have a lot of experience at looking at a child's mouth, or maybe they're just looking in the mouth to look at the tonsils or the back of the throat, and they don't necessarily know exactly what's normal. So whenever I see this photo here, this is sort of our ideal. If every child looked like this, then I would be out of a job. But this is a nice child in primary dentition. Note that you can see spaces between all of the front teeth, and that's good. That's a healthy dentition for a small child. It makes it easier for the parents to keep the teeth clean because of the spaces. And also, this child's going to be likely to have room to accommodate all of their permanent teeth once they come in. This child has healthy gingiva, just to go back, healthy gingiva, which is nice and clean. It's not red or inflamed. It's healthy pink. And you can also see how the child's teeth are nice and shiny there, which means that someone's brushing their teeth. So some people ask, you know, is dental caries still a problem? Is this something that, isn't this something that kids don't get cavities anymore? And unfortunately, we wish that was true, but it's not. Caries is still the most prevalent infectious disease in the nation's children. It's more prevalent than asthma and hay fever even. It's almost a ubiquitous disease in certain populations for our children. And unfortunately, almost half of the kids have had some kind of caries or cavity experience before they reach kindergarten. So we know that this is affecting children at a very young age. Finally, this is one of the more alarming statistics. Traditionally, the rate of caries have been on the decrease since the advent of fluoride. However, our last or most recent National Health and Nutrition study found that we're seeing an increase in dental caries, and this group is actually in the youngest children, the children aged 2 to 6, who can be some of the most difficult children to treat as far as their behavior management for getting their fillings. A lot of times kids in this age group need some type of sedation or general anesthesia, so it is alarming that we're actually seeing an increase in this very young age group. Okay, So just to sort of graphically review what we talked about, that caries is a very prominent disease in young children. The dental caries, too, this is another graph to show you, and it introduces the term ECC. That stands for early childhood caries. And again, the early childhood caries is when you find cavities in children 6 and younger. This study sort of mimics what we found in that National Health and Nutrition study, that in our youngest children, those children younger than 6, we're actually seeing a rise in the number of dental caries. As with many things, caries is not evenly distributed throughout the population. You are going to see cavities in children of all economic statuses. However, children that are poor tend to have more, a higher risk for getting caries, and also they're more likely to have dental decay that's not treated. In addition to economic status, dental decay is not even amongst all of our ethnicities as well. You are more likely to see dental caries in our minority children. Okay. So just to give you an idea, we're using terms like caries and decay and cavities. This can give you just a little more of an idea of what we're talking about in these very young children. This is definitely a case of early childhood caries, and this is a severe case. At this point, the child has cavities in all of the primary teeth, and many of the teeth, almost all except for those, we could possibly save maybe one of those very back ones, are going to need to be extracted. So if you can just imagine what a serious condition we're talking about, how much pain this child is in, how they are not likely able to have a healthy, nutritious diet, you can see what kind of problem we're talking about. Okay, and again, just to go back, this is another case of a child, and this child is actually under general anesthesia, and you can just see how severe the dental decay is, that they're going to have to lose at least some of their primary teeth. The rest of them are going to need pretty serious restorations, probably pulp treatment, and we just have to think about what kind of impact does this amount of dental disease have on the child, on the family, and problems associated with it. Okay, so again, just sort of probing a little bit more into this issue. In one study of patients who presented with pain, almost all or most of them reported that the cavities interfered with the child's ability to eat. And again, it tends to select for children to eat foods that are softer, richer in carbohydrates, and usually not as healthy. About 50% reported that it interfered with a child's ability to sleep, and that probably interferes with parents' ability to sleep as well, and possibly with parents' jobs. The other third of them reported that it interfered with a child's ability to participate in school activities. So if our children are sitting in their school classrooms with a toothache, they're probably not as likely to be able to learn. So again, just some more images to show you what type of dental decay burden that we do see in America. And again, it's not like we take a picture of these kids because they're the worst cases we've ever seen. They're actually pretty routine if you're working in certain parts of America and in certain practices to see children with this kind of dental decay. From a financial standpoint, one of the things we have to look at is how much does it cost to restore teeth that are in this bad of a condition. One study from 2000 looked at children in Louisiana that were treated in a hospital setting. So these children had decay so bad that they had to be put to sleep to get the teeth fixed. 60% of those children were were 3 years or younger, and the cost they estimated was about $1,500 per admission. So again, children with this amount of dental decay, it's not a very cost-effective way to render dental treatment, just to put the ones that are in the worst shape to sleep. It's a very expensive burden to our health system. Okay, and again, just some more images of what our little kids go through, and this was another child that had to be that needed general anesthesia to get his dental caries treated. Another study actually looked at facial cellulitis. So whenever you have dental cavities or dental decay that are as serious as the pictures we've been showing you, the child runs a very high risk of having an infection associated with that, that decay. And sometimes these infections are so bad that they can cause facial swellings that need to be treated in a hospital setting. If they're not treated appropriately, the child runs the risk of dying from either a brain infection or from an obstructed airway. So one study that looked at the cost of admitting children for facial cellulitis found admissions were around $3,223 per odontogenic infection. So again, typically, usually as a result of this amount of money, the child only has one tooth treated, and sometimes it's not treated at all. And again, that study was done in 2000. I would guess that that price has either doubled, if not tripled, since then. So I think this is a really nice visual. It's from a cover story from our Journal of American Dental Association back in 2009. And it really looked at the cost associated with early childhood caries. So again, some of the things we've talked about already, that we have the children having to miss days from school, parents missing time from work, inappropriate use of over-the-counter pain medications, which is important. Those are all costs. But then when we go up the pyramid a little bit to the family-associated morbidity, these dental infections have the potential to introduce a lot of stress into family lives, especially families that already have a lot of burdens, such as missing work whenever they're a temporary employee, or the child not doing well at school and having to miss school even if they're already at risk for being behind for their grade level. Once we go up the ladder again, we can see that there's a cost to society financially through the hospital costs, and then there's always the possibility of death, either from the actual infection itself or the procedure to treat the infection. So these dental caries have different implications for society. Okay, and this is just to go and show you some of the effects of dental caries. These are some of the facial swellings that can occur as a result of a tooth infection. You can see the little boy on the left there, how red it is around his eye. That's extremely dangerous because right behind your eye is your brain, and these upper tooth infections can go to the brain fairly quickly and cause a life-threatening infection. The picture on the right with the little girl, you can see how swollen that jaw is. If that infection goes underneath the mandible or the lower jaw, it can become so large that it can actually close off the airway and cause something called Ludwig's angina, which can cause death as well. So that's why these infections are pretty serious. This next slide is an especially tragic story. This is a photograph of a patient, Diamante Driver, who was a little boy in Maryland who had a dental infection. He actually had multiple cranial surgeries to treat the infection and still passed away. So again, I think this young man has become the image of why we need to stress the importance of dentistry for all children, and especially for preventing these types of infections. So just to sort of talk about, cost effectiveness, preventive care every 6 months is only around $100. Extraction of an infected tooth, $80, and yet we still have children that are, costing society $250,000 to treat these infections and still passing away. So from a cost perspective, it's unacceptable, and then from just an emotional or a human perspective, it's unacceptable for children this day and age to pass away from a dental infection. And in addition to all of the ways that we have to treat dental caries, the one thing is, like most of our problems in society now, it's almost 100% preventable. So for the rest of the talk, we're going to talk more about how we can incorporate prevention into our medical practices and help prevent all of these poor kids that we've looked at so far in the presentation. So again, infant oral health, it is true prevention. These studies that we looked at, we're talking about kids that are 3 years old and that are already having a great burden of caries. If you look at when a lot of people think of when the kids are supposed to go to the dentist, they think that kids aren't supposed to go to the dentist until about age 3, and that's not the case. So infant oral health is about true prevention and getting kids into a dental home before they start to get cavities. The also advantages of this are just that it's a proactive measure. We're not waiting for something bad to happen to the child and then treating it, but we're trying to prevent it. We know that these habits that the kids learn as infants and grow up with are going to be promoted for life, so incorporating good oral hygiene and dietary habits is a lifelong habit. We can prevent pain and suffering, and it is cost effective, as we're going to look at. So again, why are we looking at infants? Why are we talking about infant oral care? And that's because among 1-year-olds, between 36,000 and 62,000 toddlers have experienced dental decay. So we need to start at age 1. We need to start as soon as we can to help get the word out to prevent these children from suffering the burden of care. So we mentioned a little bit earlier about early childhood caries, or ECC, as we looked at in that one graph. And again, this is an especially strong or dangerous form of cavities where the teeth start to decay very soon after tooth eruption, and you start to get decay on areas that normally don't, such as the fronts of the front teeth. And this is the early childhood caries that we're trying to prevent from happening. And again, this is why we want to incorporate the infant oral health and the dental home almost as soon as our patient looks like this. Okay, so in order to really understand prevention, we sort of have to have a step back and look at how a cavity forms in the first place. And to have a cavity, you need 3 basic ingredients. Okay, to form those caries. So the first ingredient is bacteria. And the bacteria that causes cavities is pretty ubiquitous amongst humans. However, we do know some strategies to help prevent or delay the time that the bacteria is acquired, and also how to reduce the load. The next ingredient to make a cavity, so that's what we're going to start with today, or right now, with bacteria. So the primary bacteria in the mouth that causes cavities is Mutans streptococci. And it's transmitted vertically, and that means that it's transmitted typically from the primary caregiver to the baby. So normally any kind of saliva sharing activities such as cleaning off a pacifier, sharing a spoon, things like that can help, can cause the bacteria to go from the parent to the baby. Usually it's from the mother, but again, it can be from whoever is the primary caregiver of the baby. And these bacteria typically start to colonize as soon as the teeth are present. Okay, so our bacteria, you know, again, we can't prevent, there's no vaccine to prevent the children from getting these bacteria, but we do have some strategies. The first thing is to reduce the bacterial load. The way that we can do this is to provide dental care for expectant mothers. We can provide oral hygiene for mothers. We can advise mothers not to engage in saliva sharing behavior. And we can talk to them about starting to brush the teeth as soon as the teeth erupt, and that will help prevent the load of bacteria by cleaning them off on a daily basis. The next ingredient to make a cavity is the surface for colonization. So whenever we look at the surface for colonization, you know, we all have teeth. We're not going to take out the baby's teeth just so they don't have cavities, but we can make those surfaces stronger. And our main way that we make our teeth stronger is by incorporating fluoride. Appropriate fluoride use can take those surfaces of the teeth that are weakened by cavities and make them stronger. Some ways that we can help our children get the appropriate amount of fluoride is to encourage them to drink optimally fluoridated water and then to brush twice a day with fluoride toothpaste. Now again, there is such a thing as too much fluoride that we all recognize. So, for example, the amount of toothpaste on the toothbrush to the left is inappropriate for a young infant. That's way too much toothpaste. So this picture is a little more like it, how much toothpaste we would like to have for a child age 0 to months to 3 years. So just a smear, just barely wetting the bristles. Once the child has learned to spit out most of the toothpaste and doesn't just suck the toothpaste off of the toothbrush, then we can start to use a pea-sized amount of toothpaste, as the lower picture shows us. Again, a small pea though. Okay. Fluoride supplements are another option. With our fluoride supplementation, though, we do have published guidelines, just like we are showing here, that show how much fluoride should be used. So we want to make sure that before we prescribe any fluoride, that we're making sure that the child doesn't already have fluoride in their diet. So for example, you might have a parent that tells you they drink well water. Well, some physicians will jump right in and write the fluoride prescription, but we really need to go in more depth. First of all, we need to find out, is that well naturally fluoridated? Because if we're giving them supplements on top of that natural fluoridation, then we're going to give them too much fluoride and put them at the risk for fluorosis. The other thing you want to check is, are they actually even drinking that water? Most of our children now drink a lot of bottled water, and depending on where the water is bottled, then they may be getting adequate fluoride from their water alone. So I would encourage you to probably be more likely to use things like the fluoride toothpaste before you jump into the supplements, and focus more on the topical toothpaste. Okay. The last thing, the ingredient to make a cavity, is the fermentable carbohydrates. So basically, this is food for the bacteria. This is really the area we need to hit hardest, and the area I believe that we're seeing the rising caries rates in our very young children. Almost all of the time, if we see a child that has cavities on the front of their front teeth or smooth surface cavities, then it's almost always associated with a bad diet habit. So they're drinking too much of a liquid that has carbohydrates. It may be the child is going to bed at night with a bottle, which obviously can cause baby bottle cavities, as it used to be called. Or it may be that they're just taking the juice sippy cup all through the day. Both of these are associated with early childhood caries. Another concern, not as much of a factor, but the child that sleeps with a mom at night and nurses throughout the night, if they have anything in their diet other than that breast milk, if they're eating cookies, if they're eating other foods, that combination of the carbohydrate from other parts of the diet and the breast milk together can cause cavities as well. So usually once the teeth erupt, we want to discourage the free breastfeeding throughout the night. However, our main culprits are the different juices and drinks that the kids are drinking. So for example, you know, we look at these juices here and they all look extremely healthy. However, once we put the nutrition facts up, you can see that that apple juice there has 10 teaspoons of sugar, as I have highlighted. And our grape juice has 15 teaspoons of sugar per glass. So again, these are pretty, these drinks, it's the same as if a child was able to use a spoon and dip 15 spoonfuls of sugar into that 1 glass of grape juice. So these foods, even though they're juice, are not healthy for the children. And when you look at the way that many of these drinks are marketed, then it's not, you know, it's no wonder that the parents don't understand that they're not healthy. A lot of parents think that these juices are necessary for their children so that they're not malnourished or so that they get the vitamins they need. Really, they're just sugar water with some vitamins added. So one of the major parts of any infant oral health program has to be informing parents about what is in the drinks that they drink. And again, the best drink for the children is water. And obviously, these are some of our drinks that have other drinks that have a lot of sugar in them. As you can see by the little labels that are going to pop up, these have quite a bit of sugar, not much more, though, than the juices that we were talking about. So, of course, we need to advise parents about the dangers of sodas for their children. And all candy does have sugar unless it's labeled sugar-free, but there are certain candies that are worse than others. So, for example, these caramels or these gummy bears have high substantivity, and what that means is they're going to stick to the teeth. So they can continue to release sugar into the mouth long after the child eats them. So these are also not good choices for snacks for the young child. So what are our recommendations regarding juices then? Our recommendations as pediatric dentists fall in line with the American Academy of Pediatrics, and we recommend that children that are 6 of age or younger don't drink any more than 4 to 6 ounces of fruit juice a day. So this is a pretty small amount once you actually pour out 4 to 6 ounces. So again, 1 time a day and no more than 4 to 6 ounces. We do recommend that these children drink it from a cup, and it should be part of a meal or a snack. So what we don't want is we don't want the child sort of all throughout the day having the sippy cup. One thing about this guideline is with the 4 to 6 ounces, a lot of times people think that if they cut it with water, then it's going to be okay. But cutting it with water really just makes it more juice. It's still got sugar, and it can still cause cavities. So even cutting it with water is not a good recommendation for parents. So what are some strategies that we can talk to our parents about? First of all, once the teeth come in, parents should not be put to sleep with a bottle containing any fermentable carbohydrates. So no juice at night, no milk at night, no formula at night. They shouldn't go to a bottle with any carbohydrates in them. Breastfeeding on demand should be avoided after the teeth are rough and other carbohydrates are introduced. Once kids turn 1, we really want them to get rid of that sippy cup, and we want them to transition to a regular cup where that they're not going to have the all-day drinking from the cup. Infants should be weaned from the bottle at about 1 year of age, and then again, any kind of carbohydrates in a no-spill or training cup should be avoided at this age. We also want to talk to our parents about snacking and make sure that if they're snacking, they're choosing healthy snacks, and we're not having many snacks that have fermentable carbohydrates such as candy throughout the day. And again, parents sometimes ask, well, what can the kids drink? And by far, water is the best drink for the teeth. Anything other than water should only be with meals. So if it is that 1 cup of juice that kids can have a day, then they can have it, but only with a meal. So again, caries is essentially a behavioral disease and essentially preventable. So this day and age, you can't have kids without cavities, and we do have caries-free kids come through our clinics. And if you do all the right things, caries isn't an inevitable thing that happens to all the kids. All kids will get cavities. You can raise a caries-free child. Okay, so now we're going to go into risk assessment. We want to focus most of our counseling towards children who are high risk. So what are some factors that we can recognize that a child is high risk? Well, first of all, we can look at their history. If mother and siblings have cavities, then they are more likely to get cavities in the future. Children with low socioeconomic status do tend to be at higher risk for caries, so that's also another factor. If you look at a child and they're having more than 3 meals with sugar and with snacks and beverages, they're going to be at high risk for future caries, especially if they're being put to bed at night with the carbohydrates. Other concerns are children that have special health care needs that may have obstacles to getting dental care, and children that are recent immigrants and may not have the network to get the dental care they need. Now, if you're actually looking at the teeth themselves and you're trying to determine if a child is high risk, if the teeth have plaque on them, if they look fuzzy or like they have a film on them, that child is high risk. White spot fillings, we're going to look at some pictures of those in a few minutes, but those are pre-cavities. And again, that's a sign of high risk for future caries. And then obviously if the child has already had caries in the past, then they are more likely to get cavities in the future. So this is a nice form, and this can be downloaded from the American Academy of Pediatric Dentistry website. But this is a caries risk assessment, which basically summarizes what we talked about and is a nice visual for you in your practice to determine what the caries status of a child is. So preventive intervention usually focuses on doing a caries risk assessment, and if indicated, the application of a fluoride varnish. We definitely want to do oral health education for the child and the parents, and we want to promote the regular oral health appointments with dental providers. So when a lot of times parents ask when we're recommending that 1-year-olds come to the dentist, how do you look at a 1-year-old? How does a 1-year-old get in the chair? And we normally don't even put them in a chair. You don't need a dental chair to do these exams. We do routinely knee-to-knee evaluations or examinations where the child stays in the mom's lap, puts their head back on the medical provider or dentist lap, and has their teeth looked at that way. It's sort of a little, take with you dental chair. The other thing is it's a very comfortable way and consoling way for the child to stay on the mom's lap while getting their teeth looked at. And this is a nice photograph of some intervention and prevention that we did in one of the FQHCs in Louisiana, where the medical assistants were examining patients in the knee-to-knee format and applying the fluoride varnish. This is, again, an example not of a dentist, but of a physician's assistant or medical assistant, applying fluoride varnish for the first time on the patient, and they did a great job. So it's not very difficult to do. You want to dry the teeth first, and then you want to apply the fluoride varnish with a brush to all the surfaces of the teeth. And just another picture of how the teeth look with the fluoride varnish. Again, so we're going to start looking at a few pictures of teeth, and this is a nice photograph that we started off with, just showing all the healthy aspects of the primary dentition. This next photograph, I think you can definitely see some differences. First of all, you can see that the teeth aren't uniformly nice and shiny like the other photograph. They look sort of rough and dull, and that's plaque on the teeth. So we've got some kind of food or plaque sitting on the teeth. Also, if you look between the two front teeth, you can see how one of the teeth is very white there. That is a pre-cavity or a white spot lesion, and that's an area where the mineral has been, the calcium or minerals have been taken away from the tooth from acid, and if that isn't arrested through fluoride and continues to develop, then that child will have a cavity in that area. This photograph, it's a little hard to see the teeth because it's overexposed, but I think you can note how inflamed the gums look in this photograph along the back teeth. They're red. They look like they would be easily bleeding and bulbous. And this is a photograph that shows gingivitis in a very young child. And it's not normal to see gingivitis on children this young, so you have to suspect that this child isn't ever getting their teeth brushed. So this is a sign of poor brushing in the child. Again, this really shows you how caries can affect the very young children. this child is probably close to 12 to 14 months and doesn't even have all of their baby teeth in, already you can see that white line along the gum line of all of those primary teeth that is a pre-cavity that will soon cavitate. And then also you can see the rolled, enlarged gums that look like they could bleed easily, and that's a sign of the gingivitis. This is just another example, again, of a very young child who doesn't have very many of their permanent teeth in, or primary teeth in. They're probably closer to 1 year of age. And you can see the definite white line along the gums. And you can see a very white area there with the arrow. And at that point, I think if we were to take an x-ray of this tooth, it already has a cavitation that would show up. At this point in time, this child already needs some kind of restoration, if not a crown for that tooth. This is another example of a different area where these cavities can occur near the biting portion of the tooth. And at this point, this tooth does have a cavity and needs to be restored. These are some more cavities on a very young child. These cavities need anything from some small tooth-colored fillings to the cavity on the right side of the screen needs probably at least a crown on it at this point in time. So again, probably a small white filling may work there, but that tooth definitely needs a crown. And again, just another way that the dental cavities can look a little different. This is a picture again of a young child that all of the primary teeth haven't erupted yet. Again, probably closer to 12 to 14 months. And at this point in time, this child definitely needs crowns on those front 4 teeth. And at this point, maybe even needs nerve treatment with that tooth that's severely decayed. So we're seeing some pretty advanced cavities in a very young child. And this is a picture of even more advanced dental cavities on that tooth on the right. You can see that most of the tooth is missing. At this point, that tooth probably needs to be extracted, which means that this child will not have another tooth in the front of their mouth until they're about 7 or 8 years of age. Now this photograph's a little different. I think that you can see that the teeth in the center are a little different. They look more grayish, and this is actually a sign of trauma. So whenever the teeth look discolored or gray throughout, this is a case that needs to be referred to a dentist immediately. This is probably a child that fell and bumped those teeth, and now the nerves of the teeth have died. Now, another topic that people ask a lot about is teething. And see, the medical professional that's looking at the child's teeth may get questions about teething. It's not uncommon to have some irritability, some abnormal biting when a child is teething, maybe even a mild temperature elevation. However, if the child is showing symptoms such as a fever over 104 degrees, diarrhea, vomiting, things like that, the child is probably truly sick. So if anything, I feel like I see medical professionals take a sick child and try to blame it on teething. So really, anything other than irritability or some very minor temperature elevation should be considered strongly that there's something else causing the child to be sick. Now, what can you do for teething? We usually recommend some pressure, some cold pressure teething rings, a non-aspirin analgesic, increased fluid consumption. Another change recently is that the benzocaine or the Orajel that contains benzocaine is not recommended for children under 2 years of age, so that should not be recommended. However, there's some new products on the market that do not have the benzocaine in them. So again, why are we talking to physicians? Why not just to other dentists? And that's because the mouth is part of the entire body, and there's no reason to artificially not look at the teeth and just assume that the dentists are doing that. We really do need the help of the medical community to start promoting the dental home, and it's a more holistic approach to the medical home, and it helps make that connection between the mouth and the body for parents, helps give them direction in establishing the dental home, and it helps secure referral sources for this area of oral health. So you want to make sure you know who in your community is willing to see your children and then that you can refer to. So again, the dental home, we've sort of talked about it throughout the presentation, but basically it's similar to the medical home where we don't want to only see kids when they're in pain or have an emergency. We would like to see them routinely and help them maintain their good health. And if there is a medical emergency, such as a fall or a trauma, we want them to have the same dentist that they see for their good health to also treat those conditions as well. So the H1 dental visit is recommended by the ADA and the AAPB just to help promote prevention, monitor good health, treatment if dental caries do arise, or treatment for emergencies. So we want this to be a resource for parents in health and harm. And with our early visits, the main thing that we're doing at these early visits is preventing and educating parents about how to take care of their child's mouth. Whenever we do see a lesion that is not advanced, sometimes we can treat it chemotherapeutically and help prevent it from getting any larger, or we can treat it with minimally invasive dentistry and possibly avoid a sedation or a general anesthesia appointment. So for example, if we were able to see this young child right away, we might be able to put some fluoride varnish on those white spots on the teeth and help arrest the caries. Also, the tooth in the picture now, this might be a tooth that we could take out the cavities with in a non-invasive approach and put on a fluoride-releasing filling. And again, we might be able to avoid a general anesthesia appointment for this child. So we had talked about the cost effectiveness and the lack of cost effectiveness with treating dental caries in young children. You know, one might want to ask the question, well, does this much prevention or this many preventive visits, is it cost effective? And the answer is yes. The children that, in one study, the children that were seen before their first birthday were much more likely to have preventive visits, and they were less likely to need to come back for fillings or have emergency visits. And again, you know, many of you guys in your medical environment aren't necessarily prepared to deal with this kind of situation. So by establishing that dental home, the child has a place to go to when childhood trauma happens to their teeth. And in some of our very sick children, this prevention is all the more important. Our children with chronic or acute illnesses of childhood, such as sickle cell anemia, cardiac abnormalities, hemophilia, cancer, and developmental delays, face so many obstacles in getting help. Sometimes they also face obstacles finding dentists who are willing to treat them, and providing treatment for them can be very difficult. By starting them on the right path for prevention and preventing the dental caries, you're doing these families a great service. Community outreach, sometimes that you can do this, or you can look at groups where the kids gather, such as schools and Head Start classes, daycare settings, Bible schools, camps, and health fairs. So some community outreach opportunities may be Head Start screenings. For example, this is where Carrie, the tooth fairy, went with Linda, the tooth painter, to go see some very young children, and to do a screening and a fluoride application. So there's a good idea whenever you are promoting oral health to have some pediatric dentists in your area that take a variety of insurances so you have a place for referral. And whenever you're looking at these dentists, some things you might want to ask about are, what ages do they see children? Are they willing to see your medically compromised children? Do they have a variety of behavior management techniques? And do they see emergencies or trauma? So these are some good questions you can talk to the different providers in your area about whenever you're establishing referrals. And again, some other clinics that you might not even have thought of could be primary care clinics such as FQHCs, school-based health care settings, and rural health clinics. So some of them might have dental programs that can help you be a source of referral for your patient. Okay. And we are always happy to help in Louisiana. This LSU School of Dentistry is the only dental school in Louisiana. We have 2 clinics, one at Children's Hospital and another at the LSU School of Dentistry. If you ever have any patients that are in need of oral health for the child, you can refer to either of these clinics, and we would be very happy to see them. And again, thank you for being with us this afternoon and looking at this presentation, and thanking you for helping us take care of our children.
Thank you, Dr. Townsend. Again, if you have any questions, please type in your question on the right side of your panel under questions. Dr. Townsend, are you ready for some questions?
Sure.
I have a couple. Okay. So the first question is, can you apply varnish if the teeth are not cleanly brushed?
Yes, you can. We have studies that show that cleaning the teeth before a varnish application is not necessary. It'll still stick to the teeth. Now, the one thing you do need to do is you need to dry off the teeth. The teeth need to be very dry before you apply the varnish.
Okay, and then how often can you apply varnish?
It really depends. If you're applying varnish in a preventive type setting, probably every 3 months should suffice. Now, if you are chemotherapeutically trying to treat a cavity by arresting it, sometimes we apply varnish as much as every week. I think that should probably take place in a dental office setting, though, where they have the opportunity to take x-rays of the tooth as well, and then if the tooth caries does not arrest, be able to treat the caries.
Okay, and that seems to be the end of our questions. The PowerPoint presentation will be sent out to all of the attendees. And Dr. Townsend, would you like to provide any additional information?
No, I think we're good.
Okay. Again, thank you for attending the Infants and Children Oral Health webinar, and thank you to Dr. Townsend for presenting such a great webinar.
Thank you.
Okay. Have a great day.